I think we'll just make a start with the minutes and the action plan and so forth, and then that'll just allow any time for anyone who's going to join us a few minutes late to catch up. So welcome everyone to the first meeting of the Health and Social Care Committee of 2024. And I can actually say, yeah, we've actually got a blizzard in Orkney as well, so it's very unusual for us to have snow that lies, and I can assure you it's most definitely lying. Okay, so we don't have our usual excuse of actually saying we all need to get away to get home. So, but we'll try. You'll notice today we've got probably a shorter in length agenda, but I think there's some really good topics on there that merit some discussions. And the clue to being shorter in length is we can restrict it to 2 pages. And I think that's maybe the task we need to take for all of our meetings, is to see if we can keep the agenda to 2 pages. 3 pages probably tells us we've got too much in the agenda. Anyway, welcome to everyone. And first of all, just say I'm delighted to welcome Diane van Rutenbeek with us today for her first meeting of the Health and Social Care Committee. Diane has joined us just early in the new year there as the third of our independent lay members. And I'll maybe just invite Diane to say a few words to the committee and introduce herself.
Thank you. I'm really pleased to be joining the board, and I hope to be able to make a useful contribution. I moved to Skye 9 years ago now, and before that I lived in Manchester. I'm an organisational psychologist professionally, and I've worked with the NHS for about 30 years, I think, on all sorts of different issues, including workforce planning and development, patient experience, and issues around cultural transformation. And I was the board of NHS. I was the chair of the board of NHS East Lancashire for 3 years from 2012 to 2015. So I'm looking forward to joining you.
Thank you very much, Diane. We're looking very forward very much to your input into the committee. We talk about lots of things, and so there's always an opportunity to participate. So we just tend to operate. If you feel you've got anything to say, just raise your hand. I'm sure Ruth has told you all of that. And if I don't see your hand raised, by all means, just button at some point. Just because I might not see it there. So thank you very much indeed, and welcome to Diane. Stephen, do we have any apologies?
Yes, we've got apologies from Kate Stoomigan, I think Claire Copeland as well, and both Ron Gunn and David Fraser will probably have to leave about 2 o'clock.
Okay. Declarations of interest. Does anyone have any declarations of interest which they wish to make in relation to any item on today's agenda? Not seeing any hands, so we will minute that there are no declarations of interest. The assurance report, you have in your pack the assurance report from our meeting on the 1st of November 2023. Seems a lot longer ago. That's what happens when you have Christmas and New Year in the middle of that. I will not run through it page by page, but in my usual fashion, I will ask any board member who has got any matters of accuracy they wish to raise on that assurance report stroke minute. Again, not seeing any hands, so I will take that as an accurate reflection of our discussions on the 1st of November and record it being an accurate reflection. Now, does anyone have any matters arising which we are not going to cover in the action plan or later on the agenda, which they would wish us to cover right now? No, again, no hands, so we're going to take that as no matters arising we're not going to touch on later. We'll move to the rolling action plan, which you have got a table there. We're proposing that the staff experience item we can close and we can take off of our rolling action plan. I'm going to suggest that items 2, 3 and 4, which are the primary care improvement plan, the care governance framework, and the finance update stroke about day centres, which is actually a wider piece about learning disabilities, we'll actually capture in the work plan for 24 25, which we'll hopefully be bringing a draft of to our next meeting for approval. What else have I got there? I think the terms of reference we've got on the agenda. We'll bring our committee work plan for the 24-25 to the next meeting. And the issue around technology-enabled care, which is actually a wider issue around about the switch off of the analog signal across, in particular, Highland is where we're concerned about. That again was raised at the Joint Monitoring Committee as well. So I think, and I have also discussed it with board members. So I think I'm going to propose that we can close it as an action for this committee, but I will ask, obviously, and I know she will do that Pam and all of her staff keep it very, very high up the agenda, and I know certainly our e-health team and our tech-enabled care team are very cognizant of the issues that may well be arising due to the analog switch off, and I've seen issues in other boards. So, but I think in terms of the role of this committee, we've probably done what we can do in terms of highlighting the issue. So I'll propose that we close that one off. Everyone okay with that update on the rolling action plans? Excellent. Thank you very much indeed. Now, I suspect in a change of convention, and I suspect not a sign of things to come, we're actually going to talk about quality this afternoon before we talk about money, which is this was originally intended to let Louise get to her next meeting, but I know she said she doesn't need to get away quite as quickly as she had to do. But I think it's actually a good message if we actually talk about quality first. And this is an important piece of work, and I think Louise is going to take us through some slides, and then we can just have a discussion. And I think it's probably the context here is how do we reflect this in everything we do in a health and care setting? And I think that's really the question for us. Thank you, Louise.
Thank you, much appreciated, Jerry. And you're absolutely right. It's nice to start with quality and not always with finance, although we know that the two have to be in the same field of vision, if you like. So what I was going to suggest, I'm not going to go through the S-bar, but I am going to go through the slides. Some people in the room may have seen them at least once in other forums, but bear with me. The real meat of it, I suppose, is to get people's views on what I present, as opposed to necessarily spending too long looking at the slides themselves. So I will do the inevitable thing where I try and share my screen and see how disastrously that goes. Hopefully not too. Okay, so if folk could tell me if that's coming up for them.
Yeah.
Okay, and is that in slideshow mode at the moment, or is it still?
No, it's not, Louise.
It's plain silly beggars at the minute. I'm pressing. Aha! It might have done it now, or is it showing the other version?
No, that's it.
Perfect. Okay, so the backdrop to this really is obviously I came into post last February, and Boyd and I had a lot of discussions about the fact we were in a position where as we came out of COVID and hopefully never back into it, fingers crossed, we really wanted to revisit quality in its widest sense, because we'd had such a focus on the required work around COVID for 3 odd years. We needed to sort of say, where are we at with ensuring that we provide quality services? And we felt that there had been much more of a focus on quality improvement in recent times rather than quality per se. So with that in mind, we asked Amanda Croft, who was the Chief Nursing Officer for Scotland and has previously been a nurse director and chief exec herself, just to come in and review her thoughts on where, as a board, we were around quality. And she interviewed a number of people to do that. She also then came back with a report, which hopefully folk have seen at some point, most of which is in this presentation, to be fair. But she's made suggested recommendations rather than hard and fast recommendations, just so that we can use the backdrop of those recommendations to say, is that really where we want to go as a board, and how do we want to go there? So that's the background, really. That's the sort of wider background context in terms of policy and in terms of originally going back to the quality strategy from 2010 and beyond. So one of the things we wanted to really get to the nub of is that quality should be about everything we do. It's not just about qualitative measures, it's about quantitative measures. It's about how we govern and monitor everything that we do within our areas. But there's also an element of celebrating where we're doing things that are really good quality already, because there's lots of that around. I've had recent treatments that have been very high quality in my view of the world, but I don't think we always necessarily see that and celebrate it. We might see the numbers, the waiting times, etc., but are we seeing the backdrop of the good quality that goes on behind that? So in the quality review, it was, how do we make patient quality and safety better across Highland? So there is that clear link between quality, safety and risk, and we need to keep that focused as we go forward. What Amanda did was she interviewed a number of people. She took them from various different professional backgrounds, and then she put some highlights and, as I said, suggested recommendations. So the themes that she came out with were very much about how do we revisit our approach to quality in general? How do we lead and direct that? How do we ensure that we look at patient experience engagement consistently and effectively across the board and use it along with the data that we get from all of our different routes? How do we make sure our systems and processes help provide quality, don't hinder it? How do we ensure that the people that work within the board all understand and appreciate the importance of quality and have that in their mind as they're providing services? How do we put it into everyday language and ensure that we are a learning organisation? And a big feature of a lot of the conversations we've had since then has very much been about how do we make this part of the culture of the organisation? So I'm not going to go through all of these highlights. I'm sure you'll have seen them anyway in the slides. Hopefully they've gone round. But some of the key ones for me were very much about ensuring that we have an ambition to achieve a quality service and a quality journey, how we make sure that we're very clear on what that means and how we do that, and also how we establish a focus on health and social care. And so these are the suggested recommendations that came from the report. They include what I mentioned earlier about acknowledging good practice and what works well. It talks about ensuring we have a clear definition of what we mean by quality. How do we explore it both at a local and unit level, but also organisation wide? And how do we care with compassion, which is at the end of the line, but it probably should be at the top of the line. So in the intention for getting through the work we've done, what we've done is we've gone to a number of the professional committees, and the professional committees have included the Area Clinical Forum, the NMAP Advisory Group, Area Medical Committee, Pharmaceutical, Psychology, NMAP Assurance, and also we've got the Social Work Advisory Committee on the 1st of Feb. And from those committees so far, these are the feedback arms that we've had. So we've had feedback about making sure that we have that health and social care language, because the recommendations, I think, because of Amanda's background, do read a little bit healthy. But that's not a criticism, because actually the things within them are really good. We've just got to make sure that we get the language right and the implementation. There's also very much a focus on making sure that this is led by our clinicians and our professionals, but also that we agree the priorities and we're ambitious. We don't try to do everything all at once, but we have a clear target of where we want to get to. And again, all of the groups stress the importance of culture and the importance of how do we influence as leaders within the organisation. So those are the themes that came out. The next steps, as I see them, as Boyd sees them, is that we agree some of the definitions that we talked about in the recommendations. We look at what toolkits help people to become caring and responsible, safe and effective and well led in the care they provide. We look at how we communicate and engage with people, and also how we ensure that we get feedback from patients. We get that in some areas, but it's not systematic enough to make a difference to all of the services we provide. We need to ensure we've got a quality data set, not just the things that we have to report on, but also the things that we feel are really important to people. And we also need to look at how we ensure we've got dedicated leadership around this in the current challenging financial climate. So those are the slides. That's me. I'm going to end the presentation and stop sharing. And really that's the nub of what I wanted to present. And it's over to folk in the room to say, does that feel like the right messages that we're putting forward there? Are there any obvious gaps, or are folk happy and content with the somewhat adapted recommendations that came from Amanda?
Louise, thank you very much for that. I think that there are some fundamental messages in there, and I think it is crucial in terms of how we take them forward as a board, and then how we actually monitor those as a health and care committee. And I totally agree with you in terms of that language piece. Maybe while I'm giving colleagues time to collect their thoughts and maybe think about the questions. And maybe this is one for you and Pam. How do you see, because we've all, those of us who've been in the health service quite a while, have got a lot of knowledge and experience of implementing quality systems in a clinical environment. How do we see the challenges in being different in a care environment, whether it be care at home, whether it be in a care home, whether it just be on a daily interaction? That might be quite interesting just to tease that one out. Thank you.
I suppose my thoughts on that, and I'm sure Pam's got her views as well, is that there is a challenge when you're looking at a large workforce that aren't qualified as in, you know, on the wards you'll have nursing staff that are in charge of the shift, and hopefully you would anticipate within their NMC requirements, within the training that they've done, that there will be an understanding of quality, patient experience, safety, etc. We have to ensure that we've got that training and support for staff that we put a lot of onus on them working alone in isolated places, and without necessarily that level of professional qualification. We need to ensure that they have the expertise and the understanding of what they should be doing. So I think it's more of a challenge about how we get that training and development right for that more dispersed group of staff a lot of the time that don't necessarily have those same level of academic qualifications, albeit I would say some of the best care that I've received at times has been from support workers or healthcare assistants. So it's not judging in that way, but it's making sure that we give them the toolkit to be able to do things effectively. And pulling people into training isn't easy when they're all very busy as well.
Thank you, Liz. Pam, you get anything you want to add to that?
Yes, thank you. Thanks for the presentation, Louise. We're well versed in this through the board development sessions and other fora where we've considered this and as well as participating in the study. But I would say that, you know, care governance is really important. So through that mechanism, we can use and underpin care governance to you know, demonstrate some of our processes and provide that assurance. We've also got our care home collaborative board, so that in itself has got a quality element to it, you know, assuring the quality in care homes. And of course we've got partners around the table there. We've got the independent sector as well as the third sector, as well as you know, the services and care homes that we're providing ourselves. So that engagement is there and spreading that message wider than just something that's for us in terms of an NHS board. So it is resonating across the partnership that we have got, you know, the quality and safety systems in place. We've also got, you know, our adult social care and professional social work staff within our quality and patient safety processes within the board, so they're engaged in that way. And we also have an overall care board where a number of work streams report into, and that was created through the Chief Officers Group, because we found ourselves, as is the system pressures that we have in an ongoing way, often talking about delayed discharges and flow and the impact of care home closures, etc. So I'm quite assured myself that there are, you know, as a Chief Officer then, that there are a number of different forums where we can raise quality, where we can have a quality discussion, where we can reassure ourselves, and where we take that discussion, where we know where to escalate and where we can escalate to within the structures within the board and within the partnership. Okay, thank you.
Thank you very much, Pam. I've got Muriel and then followed by Kay.
Thanks, Louise, for the presentation and the clarity of it. I think it's important that I agree totally with everything you're saying, but I think we need to manage the public's perception, the public's confidence and assurance for the public, because this is where it is. And we know that we must use agency staff and different staffing pools to be able to continue to provide our service. So I think it's important that we emphasise that the staff that we're accessing have the requisite and the opportunities for the training. And equally, you mentioned our third sector and our other providers as well, which are an integral part of the whole service that we need to deliver. I think we need to have our comms prepared in light of the news today. And I don't want to talk about it, but I just want to, we'll all be aware of what came on the news at lunchtime today. So I think we need to just be aware of that as well, because there's nothing like speculative anxiety in communities without, you know, so I'll stop there. Thank you.
Thank you, Muriel. I think those were a number of very sensible, actually very warranted observations. And I think, yeah, and I think you're absolutely right. All of those points are 100% valid, and we've got to be very cognizant of them all. And it's important that the structures which Louise and Pam are talking about actually do indeed are informed by those very questions. Kay.
Yeah, I was just going to the support for staff on the ground. But that often comes from the culture of the management. So obviously managers need to be supported by higher up. You know, it's a cascade all the way down, you know, right from the top to the bottom. But, you know, if staff that feel supported and feel like they're doing a good job and everything like that, then the end user is going to get a much better experience, you know. So that's, and also, you know, when people are working out in the community alone, they need to have the reassurance that if they need help, there's somebody at the end of the phone, you know, to give them that. I was going to say, yeah, as far as training is concerned, I mean, you know, they should have access to SVQ3 and things like that. Not a lot of the quality assurance and things like that will be covered by that. And as far as third sector and agencies and everything like that, I mean, I don't know what assurance the board has really that those agencies have the same care of their staff, you know, and I think that maybe some of that needs to be sort of looked into, or assurance from that, because obviously if those staff aren't, if they've been working long shifts, if they, you know, run down, if they shouldn't have really been at work in the first place, then the user isn't going to get the experience that they should have had if that staff was being looked after properly. Yeah.
Louisa or Pam, either or both of you want to just talk a little bit about how we're actually going to support and encourage staff in this quality journey?
Yeah, and I think that the challenge for this is we know how busy and under pressure services are right now. We're already in a position, you know, Regmore was on black yesterday, it's not today, but Caithness is usually under pressure. If I just wander in and say, well, what about quality? Somebody might just throw something at me in the middle of ED. So there is something about how we frame this and how we do this in the right way. And we don't see it as blaming people for things not being quite right now, but also celebrating what's going well already. So there's something about giving ownership to each of the areas to say, you know, what would be your particular areas of concern around quality? What are your already well measured areas? What can we help you with? So it's how we're helpful to local teams about providing sort of input from the quality improvement team if they require it, but also with data, with information, so that they can understand their own areas and understand their own needs without people coming in and doing to, it's doing with. And one of the things we did where I worked previously was and I'm not necessarily saying we do this in the same way, but we introduced a gold, silver, bronze training so that everybody had a basic understanding of quality and quality improvement. Some people had a bit more, such as leaders, as Kay was talking about, and some would have an enhanced level that could come in and provide that professional expertise. So it's how we give people those skills, but also easy data and easy access to what they need. And just back to Kay's point about the agencies, we do get good assurance from the system of agency working, if you like, that there are structures and processes and governance around that, and we have a team that ensures that. The challenge around agency is people dotting around and working in lots of different places. We have some agency staff that work in the same place for years and become almost part of the team, which in itself isn't great because we'd like them to be substantive with us, but it is what it is. But the challenge is often the staff that will come in and do a shift and then they'll go somewhere else and do a shift, and you lose in that consistency and that ownership from the service. So I think that's one of our bigger vulnerabilities. And to be fair, within care, as in social care, a lot of our agency staff do tend to work in the same place for quite a long time. So at least we don't have same problems sometimes as we sometimes have an acute where people are dotting around a little bit more. So there are different challenges in different areas.
Thank you very much, Louise. Diane, you've had your hand patiently up for a few moments.
Thank you. First of all, I think just to say that I think it's a really good framework, that what's being proposed, and it covers lots of different elements which need to be, as you've rightly pointed out, coordinated in a more sort of holistic way. Just a couple of observations, really. First of all, I see that one of the recommendations is about looking at more evidence about patient experience. And I was just going to make a suggestion, which is that in my previous experience, I've found patient stories to be particularly powerful as ways of informing that, both positive and negative. In fact, Louise, I think you've already said today that your own experience has influenced the way you look at something. So just a request really that we look very carefully about how we could gather and use more effectively individual stories to inform some of that, rather than just more, I suppose, quantitative ways of collecting data. And secondly, the challenge, I guess, which has already been expressed, of collecting, I suppose, feedback data from the care sector. In the NHS, we have the annual staff survey, which, although it has limitations, at least gives us some indicators of how people feel. I don't know what exists in the care sector, if anything, to enable us to find out more clearly what those people are feeling and their feedback. So those were just a couple of observations which I hope are helpful.
No, thank you very much, Dan. And I think you've hit another really crucial point there, is how do we gather the views of staff who are not directly employed with us. And I know Louise has spoken well about agency there, but we've got a whole cohort of independently employed staff. I think we can use that term here, where it's essential that we actually garner their views as well. So thank you very much indeed for that. Sarah, I see you have your hand up.
Thanks, Jerry. Yeah, just to say thank you, Louise, for that presentation. It was actually really nice to see it today. So I saw it quite early on when it came to ACF, and so it's nice to see how it has evolved with that feedback and contribution that you've been getting as it's been going through different forums, and particularly welcome your comments about broadening that language to make it more inclusive of our whole workforce and our partners and all the people that we had a session earlier where we talked about, it's a team sport. So that was kind of clicked for me when you were talking about that broader language. That's great. I was going to make a point, which Louise has kind of already touched on, which was around the pressure that our staff are feeling at the moment, not just because of their day-to-day work, but I suppose all the asks that we as an organisation are placing upon them, cognizant of the financial challenges that we're going to talk about a little bit later, just the pressures in the system, we're pushing for better and better performance to hit our ADP targets, all of that stuff, and really sensitive to that, I suppose. Ever the optimist, the one thing that I feel quite positive about this is that if we package it up right and we get that comms right, this is something that I think our staff and our partners can really get behind, because they all come to work every day to deliver quality service, and it'll really resonate with them. Whereas I think some of the other things that we sometimes ask them to do feel a little bit disjointed from what it is that they're there to do, when they start their shift every day. So I think there is a real opportunity for us here in embedding this work around quality through everything that we do, as it should be, and all the elements of our strategy and all the elements of our delivery plan. I think it does provide us with an opportunity to that staff can get behind and we can focus on together. But saying that, there is something else for me about that realistic context. So more and more we're hyper aware of the fact that we are operating within the confines of our resources. I don't just mean financially, I mean, our workforce challenges, and I suppose the real world that we operate in. And there's something about we talk about realistic medicine as a concept, or it's not just medicine, it's realistic care, and what that looks like. And I suppose there's, how do we do that? And back to Muriel's point about the comms to the public, how do we really elevate the good work we do around quality, but within the realistic context that we're working in? And I think that that's going to be something for the senior team to take away and bounce around to get the messaging right. But I'm really, really pleased to see it here today. I think it's a really positive piece of work.
Thank you very much, Sarah. I'm not seeing any other hands up, and I think actually Sarah's comments are a good place to draw this item to a close. Actually, it's an excellent piece of work, and as a set of principles for the way forward, I don't think anybody would disagree with them. But the road forward is fraught with difficulty and challenges, and being aware of them, and not least of them is capacity, comms, getting that messaging right. But I think Louise and Pam, you can take an endorsement. I know one was not actively sought today, but I think you can take an endorsement from this committee in terms of, as an approach, we're really excited about this, and actually really looking forward to how we might actually take this forward in a care setting. And I will save my question for later on in terms of how we measure it. So when we get to IPQR, we'll touch on that. But thank you very much indeed, Louise.
Thank you, and thank you for everybody's feedback. It's been really helpful.
Louise, you're free to stay with us, or you're free to utilise the free time in your diary and go on and do some more work. Thank you very much indeed. Thanks. Okay, we're going to move on to it says item 2 in my agenda. I maybe got an older year-to-date financial position and a brief overview, I think, of the 24-25 outlook ahead. I think we're joined by Francis today, who's going to give us that. Probably just if I just open up the before Francis gets into her slides, just actually to say, we obviously were all aware that the Scottish Government budget was published just before Christmas, but I'll probably just say I'm well aware that Highland and the team are actually still working through the detail of that, and actually still in really a lot of dialogue with Scottish Government colleagues. So I don't think we can really ask a lot of questions about 24-25 and what the budget may or may not mean. There'll be plenty of time ahead for that. I think the one thing we can take from it is that it does not improve the position significantly, if at all, but actually until we get the detail of that, and Helen and the team have worked that through. So I'll hand over to Francis, who's going to take us through the month 8 position and a very brief overview of 24-25. Thank you, Francis.
Thanks, Jerry. Hopefully you've all had a chance to review the papers. So I'll share the slides on screen and I'll just talk through the key elements. Hopefully this will share okay. It's not been working very well today. Can you let me know when you see that? Fab, thanks, Jerry. Okay, so for the month 8 position, we've seen an improvement from the month 6 that was reported, a slight improvement by 151,000, moving to a year-end outturn just under 15 million. We still have a number of drivers within that position. We have our supplementary spend, which is continuing, as well as our slippage on the SIP and also the prescribing pressure. I noted in month 6, Elaine spoke about the prescribing data that we had kind of received, and that we were about, I think at that point, only 2 months of data for the year. We're now about 4 months behind, and what we've seen is kind of like the position stabilizing. So whilst we've still got the 2.1 pressure, at this moment it doesn't seem to be increasing. However, we still have the risk on the supplementary staffing, namely around the agency within our in-house care homes. So going through the various services, slippage on their own kind of saving schemes are a pressure, as well as in-house kind of business case pressures. We have a number of unfunded services as well. So we're also seeing in month 8 an increase in the cost of care packages, and that's been reflected to the year end. So if I may, I'm just going to pull up the table for the assurance table. Okay, so this was presented in the last slides, where you can see that we've got a number of schemes still in the planning stage, which poses a risk to the year-end forecast. It's just under 1.5 million there.
Francis, it hasn't changed.
Oh, is that changing now?
No.
Nope. I had a feeling this wouldn't be catching up today. Okay.
It's like the budget not changing.
Yes, it is. Right, I'm changing here, but it's not kind of coming through. Okay, so hopefully I'll catch up. So within our Horizon 1 for this year, we're showing a gap of 6.4 million, with 1.5 million still in the planning stage, of which we've to get a value on. And I suppose transferring that to 24-25, we are working on a number of plans for the next stage of Horizon 2 and 3. Pam may want to speak about that afterwards, with the kind of conversations we've been having this week. So kind of suppose going to the 24-25 budget, what is important to note is that we've got no baseline uplift from the Scottish Government. And at this stage, there hasn't been a discussion on the 24-25 pay uplift. However, that will be funded separately. But as it stands at the moment, we have no baseline uplift. So there will be funding for various kind of schemes that we normally see, like vaccinations, some of the public health measures, PPE and test and protect. And also we still to get confirmation on further kind of policy commitments, such as the mental health outcomes and ADAPT. So as it stands, for our allocation for next year is just over 807 million. So I'll pause there for any questions on the in-year kind of position, as well as for next year. Thank you,
Francis. I suppose, I mean, I'll kick it off, Francis, and I think the key one is we sit here, we're at month 8, and as an old finance person, I say we're almost reaching that point of the year where any actions we can take are almost those remedial, immediately stop spending actions, rather than good planned transformational actions coming through, and that's just because it's a factor of time. So I suppose it's where would you pitch your level of confidence in the call it the 15 million outturn figure, and that feeding into the broader NHS Highland overall position, given all the caveats that you've outlined there in terms of prescribing, cost improvement programme, etc., etc.
Okay, so we've actually just completed month 9, and there was no increase in the position. Actually, there was a decrease. So what we're now seeing is the measures coming through. So with our pay reviews and non-pay reviews, and that's been reflected in the other areas as well, like corporate services and acute. So that does give some confidence to the position that we're reporting.
Thank you, Francis. And maybe if I just put in one other question before I throw it up to colleagues. Pam, could you maybe just give us a little bit of an update and just in terms of moving into 24-25 and the transformation agenda, if we recognise and accept that maybe this year we've not got to where we might have hoped to get, and we can understand that. Where do you think you are in terms of the pipeline and any new schemes for 24-25?
So what I would say is this is extremely difficult and extremely challenging in terms of the pipelines. If we were to think about agency staffing, for example, you know, and the huge cost that we have to sustain services, it would be very difficult to withdraw agency staff, and that would have a big impact on our service. So there's things that are very difficult for us to do. Also from a adult social care perspective, then the savings that we were asked to do by the council have been difficult to achieve because they would be very unpopular, and that would impact on that quality and safety discussion that we had at the start of the meeting. However, in saying that, there are areas where we move into Horizon 2 next year in terms of our financial and efficiency plans and our service redesign plans, that there are options that we need to look at and opportunities that we're taking. So we are redesigning workforce to reduce our reliance on locums. So in mental health and learning disabilities, then we'll be looking more at how we are providing the statutory service and the legislative services that we have. So bringing services back into core delivery is an area that we're looking at so that we can reduce that locum cost. There's also opportunities in services like prescribing. So there's much more work that we can do in terms of the generic labelling, and also some work in continence and wound management that we can take forward next year. More operationally, we've got 22 GP practices within Highland that are board run, and they give us a bigger opportunity then to manage them as a board as opposed to a contractual relationship. So there will be efficiency there, and that will enable us to take other schemes forward. We absolutely need to do more in terms of the hybrid working models. We find that a lot of people have come back to work, and we need to push the hybrid working model more to allow that flexibility for staff and to make the best use of our buildings in terms of admin staff, support services, etc. So we're looking at that for next year. We have agreed, and I'll come on to that later, the joint strategic plan between NHS Highland and the Highland Council, and that gives us an opportunity to go back to the engagement with the community, with links in with community planning partnerships to think about the large scale redesign of what that means for our communities. And that's maybe going to mean looking at where we've got place-based care in terms of people who are having care in beds, whereas we might want to create more virtual beds through hospital at home and or home-based solutions with technology-enabled care as part of that strategy. So we have discussed and agreed, and we've got knowledge of those work streams. So if you think about what Tracy Ligama presented last committee in terms of technology enabled care. We're well set up for that. So we've got a number of programmes and schemes that we'll take forward into Horizon 2, and obviously we'll bring a paper back to the committee. In terms of wider working with our community and our partners, then strategic commissioning, is something that should really bring us much more efficiency as we go forward next year, much more appliance to contract monitoring, and of course finding and seeking new independent and third sector providers to work with, as well as sustaining our current providers to deliver services going forward. So I think I'll stop there. That's the kind of headlines. I'm not sure if anybody wants to add anything, or Francis, you wanted to add anything on to that, but that's kind of where we are in terms of our sort of strategic direction and the schemes, if you like, that we want to maximise next year.
Thank you, Pam. I'll throw open to colleagues for any questions. Neil.
Hi, hello, thanks for that. Francis, I was just looking at the primary care detail slide.
Mm-hmm.
And please, for my education, I was wondering where does the funding for independent contractors actually lie? Is that under GMS?
It is. It's under GMS.
Right. So
that will include the board managed as well as the kind of global sum.
Perfect. So in that case, if there's almost 2.5 million spent on locums in GMS in 2C practices, and you took that off the forecast outturn, independent contractors are doing quite well.
They have a high level of vacancies, as we know, and locums invariably are double to what a substantive member would be. So it wouldn't be quite the 2 million off.
No, it wouldn't.
Yeah.
It would be, let's say half then. Nonetheless, and I guess the point I'm coming to is that quite often I get the feeling that people feel that independent contractors almost are not controllable from a board point of view. After all, it's a contract. We have a contract. If we keep the contract and deliver it, that's it. But it seems to me from the pure numbers that it's actually pretty good value for money.
Yep. I suppose when you compare our global sum payments to the independents to the board managed, and we're experiencing the pressure in the board managed practices.
And for sure, and I would also take, as would be pointed out to me in other fora, that board managed practices tend to be in difficult areas where independent contractors have failed for whatever reason. Okay, I just wanted to make that point because with respect, Chair, I might have to bring up current enhanced service discussions from the point of view of 3.4 and risk registers, but that can stay till after the break. But thanks for that. I just want to know where it was going to lie. No problem at all,
Neil. If there's an issue you want to raise, just raise it at the appropriate point in the agenda.
Thanks very much.
Thanks, Neil.
Thank you very much, Neil. Any other questions, observations from anyone? Anne?
Thanks, Jerry. Just a few points. First of all, I was just wondering in relation to this year, Francis, or if anybody else can help on this point. I was wondering if the slippage in the adult social care savings position has been accepted as a budget pressure for the Highland Council for this year.
It's been reported through JOG, and I know Simon's got a view on this in terms of how it's presented.
Yeah, I'm grateful for Simon to come in. I think we're not looking at it as slippage. We're looking at it as services that are unfunded, and I'm having that dialogue with the council actively. Simon, do you want to add on to that?
Yeah, sorry, Chair, if this is going to sound a bit semantic, but I'm hoping the committee will understand why. We outlined a savings a cost reduction plan where we were going to achieve a number of actions. In June, there were a number of discussions taking place when it was decided to forego some of those actions, and those were actions around really quite significant changes to service. So as such, I wouldn't view that as slippage. I would view that as a decision not to take forward some proposals, because slippage sounds like we've kind of missed something or we've allowed something to slip. That there was a conscious decision taken to get to that position, which means that we've got unachieved savings, absolutely, and those will have to carry into the next year. But it's not through lack of attention or management. It's because the decision was made that the impact of taking those actions would have been too severe on the system as a whole at that point. Is that a fair enough description, Pam? I'm just checking with you because various people are involved in it.
Yeah, that's the position. That's the dialogue we're taking with the council and the language, if you like, we're using. Yeah.
Okay, so well, that's interesting to hear that discussion about the language. So, but the question remains, I guess, then, is the position regarding the unachieved savings in adult social care for this year, has that been accepted by the council as a budget pressure in their finances? I mean, not everybody will maybe have picked this up, but in the overall NHS Highland position, as reported to the Finance Committee, that's clearly an ask in terms of support for that position and potentially a risk for the overall position. So I just wondered where we are in respect of any discussions going on in relation to that. Have we made a formal request yet, or is that still to come? Where are we with that?
We're still discussing with them. We have made them aware. They're very aware of the budget position. They themselves have been looking at their own budget and what additional, savings plans they may want to engage with us about in terms of budget setting. So we'll have much more robust discussions when we undertake the budget setting. So we've had some anecdote about what to expect, but there's been no formal communication. There's been no formal agreement between both organisations. That's still to come.
Okay, thank you. Just sorry, Jenny.
On you go on.
I'm still recovering my voice here. I know you said that we couldn't look in detail at next year's position, and I agree absolutely with that, given the number of discussions that are still going on about what the actual position is in reality. But I suppose from a general context point of view, I think it is maybe I'm putting the interesting in inverted commas, but it is an issue that I think in how the overall Scottish budget is being presented and communicated in terms of the NHS position having been protected, because I'm sure that Haleth, our finance director, would have a view in terms of, I mean, I've even seen it reported as having been a real terms increase. So clearly we are viewing it as a flat cash settlement at best, with a lot of risk even still to be probed in relation to that as an assessment of the overall position. Clearly there are similar issues for other sectors. I'm sure that COSLA has been raising, similar sort of concerns in relation to the issue as to whether or not the council tax freeze has been funded or not. So I think just in terms of general context, looking ahead, whilst that is the communication nationally, that the budget has been protected, I think that it's important to recognise that there's a lot of question marks around you know, the end result for us. And the picture is certainly not any less challenging. Indeed, it's substantially more challenging than it has been for everybody, including our partners around the table. Thanks.
Absolutely, Anne, you make some great points there, and we are really engaged with, so we've got a recently appointed, I think he's been here 3 months now, Derek Brown, the Chief Executive of the Council. So, you know, we've been having regular discussions. I join their corporate management team on a weekly basis, you know, where we've been having finance discussions. So that feels very positive in terms of relationships, and I know that as a council chief executive, he's been down to Edinburgh to meet with COSLA and colleagues just around the local authority settlement. So on both sides, it's really difficult. And one of the key issues for us is the conversations we've been having with our third sector partners just around the sustainability of contracts, and when we last gave them an uplift. So if in one way the government and the media are reporting that there has been an increase to health, that's going to make it much more difficult for us to justify with our partners, you know, the difficult financial challenges that we're facing. So a really important point you make, Anne, you know, when we go out with our joint strategic plan and we're engaging with the public, we've already had feedback from them during the engagement phase around, you know, how is all of this affordable? There is no money. How are you going to deliver, you know, your aspirations in the plan? So very challenging times, very challenging times financially, but we are engaged with the council, and of course we know we've got mechanisms within the partnership agreement that we can use if we're in, you know, if we need to have more focused you know, financial discussions if we're in financial dispute. But hopefully our partnership working won't get us to that stage. We should be able to strategically, as partners, engage and resolve some of the issues and agree a way forward.
Thank you, Pam. Simon, do you have anything to add to that before I just sum up and bring this item to a close?
It's simply to assure the committee on what we have been able to do in support of what Pam's just saying. So Francis and Pam are able to confirm that what we have done so far in terms of adult social care looking forward into the next financial year is we have identified to a reasonable level of accuracy what we believe the pressures are for the next year. We've identified the extent to which those are funded or not funded. We've examined we've undertaken some initial examinations with the council on possibilities for a range of transformational schemes and the potential they might have to impact upon that. And what we've also done is been clear about what the delineated impact would be were the unfunded pressures to be apportioned across the budget heads as they are at the moment. So that would be by population groups or by population areas. And until we've had a conversation with the council, I wouldn't want to go into the specific detail of what that looks like at the moment, because I think that would be a bit unfair on everyone. But I just wanted to assure the committee we're not we're not crossing our fingers and hoping there's a very detailed exercise taking place in the background that we're actively involved in with the council, and then we'll be able to report to you what the actual position is. I hope that's helpful.
Very helpful. Thank you very much indeed, Simon. So I'll maybe just sum up this item and bring it to a close. So we're asked to note the NHS Highland financial position and actually the associated Health and Social Care Committee position. I think what Francis has said is the position at month 9, based on initial numbers there, seems to reflect where we are at month 8. So we're maybe building a level of confidence in terms of where we are at the outturn. Francis has very helpfully identified a range of issues to us, which again it doesn't answer them, but it's helpful that the range of issues have actually remained constant across the year. So we've really got a good understanding of the issues. But actually the big challenge for everyone across the whole service, NHS Scotland and local authorities, is actually delivering recurring savings, through a means of transformation. We'll get further detail, which we'll work through once we fully understand and agree the presentation of the Scottish Government, and we must emphasise at the moment, draft budget at the moment for 24-25. So we've been asked to note, and we've been asked to accept limited assurance on the financial position. Are we okay to do so? Okay, thank you very much indeed. So we'll move on to the non-financial side of performance, and I think we're joined by Rhiannon for the IPQR.
Thank you. Yes. So it similarly, I suppose, to the finance report, in that the position has stayed very similar or very static really across the year. So we have the ongoing challenges in care at home, care homes, and adult support and protection, and some reflected challenges there in flow and the picture associated with delayed discharges. I'm afraid this month doesn't show any improvement in any of those. Those are ongoing sustained challenges. However, the second half of the report is much more positive. So we have carer breaks being shown as being accessed, being utilised, and we're now about to have a Q4 release of money to support further breaks going ahead for the final part of the year, which will be reported on next time. We're continuing to show a growth in the SDS direct payments, and we've also have some great improvements, as have been shown over the year, in psychological therapies, waiting times, and also performance for the drug and alcohol recovery services is better than the national average, and has greatly improved over the year too. And I can see that that the strategy and transformation team have removed the last slide, and we'll be updating that for our next meeting in terms of what the non-reportable data shows. A refreshed look there. So in a nutshell, thank you.
Thank you very much, Rhiannon. I'll just throw it straight open to questions and reflections. Muriel.
Thank you, Rhiannon. You mentioned the drug and alcohol partnership. Now, I know that there's a lot of collaboration and funding collaboration with our third sector and partners working. Are we able to sustain what we need to do? Because there are concerns about our levels of challenges, shall we say, in the Highlands, and I think we need to keep a focus on that.
Pam, do you want to come in here?
Well, if I may, Arlene is present in the meeting, so perhaps Arlene can give us a response to your question, Muriel. And I mean, I would say that you know there has been improvement. You'll recall from a previous chief officer report about the staff awards in the area, and also our achievement in implementing some of the MAT standards, the medically assisted treatment, that has enabled access for people, you know, across the service, not just specifically for medically assisted treatment part of it. So I'll let Arlene come in, because it is more of a positive and sustainable position, I think, than maybe the graph looks like. And I see that Tim wants to come in as well. So I'll hand over to you, Arlene, to give us some assurance. Thank you.
Yeah, thank you, Pam. And I think, as you see, Tim's put his hand up, because I think lots of the work around about drug and alcohol recovery, it doesn't necessarily always sit with health professionals and the services that we currently provide, but certainly within the services, as Pam says, we're doing particularly well around about the MAT standards, and are all moving forward as we had planned and as we had hoped, and we have been nationally, in fact possibly even internationally, recognised for the work that has been done within the custody suite. We had a conversation just yesterday around about whether we need to do a national campaign about the uptake of naloxone, so that all of our staff across all of our health and social care services are carrying naloxone, and that actually we think that'd be a fairly easy thing to achieve within our services. So I think we could give you kind of quite a bit of assurance that we are moving in the right direction from the perspective of the health and social care professionals and the work that they are doing. From a how do you stop all this in the first place? That would be, I guess Tim will be able to come in around some of that work. That's kind of a more difficult, more challenging arena, I think.
Tim?
Yeah, thanks. I wish I could come up with an easy answer to say about how things could be stopped in the first place, but sadly I can't. I think but I think the point I was wanting to make, particularly around Muriel's query around the third sector and pressures on the system as a whole, I think it's twofold. There is a governance point, just for the purposes of this meeting, that this meeting it talks about health and social care services and the elements of the delivery of drug and alcohol services that are part of the work of the Alcohol and Drugs Partnership, but by no means all the work of the Alcohol and Drugs Partnership. So it is a little bit semantic, but I think we just need to make sure that that's clear from a governance point of view. And the reporting route for the Alcohol and Drugs Partnership is to the Community Planning Partnership Board. So I think we need to recognise the different ways to look at it, but that's not to underestimate the point that you make, Muriel, about the pressures that are on all the sector, and that the services that are particularly reported here with things like the MAP standards are doing really well, and there's quite a considerable improvement, but we're only going to be able to improve the picture for drug and alcohol substantially and as a whole throughout Highland by engaging across all sectors. So I think it's important when we talk about the good performance with the services that we remember that the great, particularly financial pressures on the third sector at the moment, and bear those in mind.
Thank you, Tim. I think you're absolutely right in terms of it's important to recognise that the drug and alcohol recovery service is one small piece of the fuller alcohol and drugs work, and that's one of the reasons why later in the year we bring the ADP annual report to this committee for us to note, so that we see that full picture, recognising the governance route up through community planning. But before I bring Michelle in, can I just say Pam and I had the pleasure of, we were at Dunbar Hospital just, it seems a long time ago now, Pam, but I think it was mid-November, and we spent a couple of hours chatting with some members of the drug and alcohol recovery service, and actually some of the work and some of the outcomes that they were achieving were absolutely tremendous. And I'm minded of our action in terms of how do we get more staff involvement with the committee and getting that story in, and Pam and I have still to resolve that, but actually it was truly inspiring to listen to some of the work that they were doing, and actually some of the impact they were having at ground level. So I really enjoyed that as well. I saw a number of services over a couple of days, but the drug and alcohol recovery service at Dunbar Hospital, I think, was particularly illuminating. Michelle, you have your hand up.
Hi, thanks. Sorry, I got kicked out, and since I've come back in, my camera's just black, so I've not deliberately got my camera off.
We can hear you, Michelle.
I just want to ask about the delayed discharge. As a patient myself who's just been through sepsis in my hip, I was hospitalised and was in Rigmore for 10 days in an acute ward with a delayed discharge patient. Now, I was really concerned. I brought my concerns forward to the staff there, so I have got permission from them to bring this up. But what is happening with some delayed discharge patients? Because this lady's been in there since April. She screamed and shouted and yelled day and night. She quite clearly was very distressed. She shouldn't even have been in that ward. So I appreciate that it's difficult at the moment, and you're short of staff. But what can we do to help some people? This is just an isolated case, and the staff were great. I have to say, they dealt with her really well. I was only 2 rooms up from her. The woman that was in the room next to me, who was really ill as well, cried a lot of the time because of the distress of the woman it was in this ward. I mean, what is happening? Are these patients being visited regularly and their families being kept up to date with what's going on? And why are they in, you know, an unsuitable ward environment since April? You know, what's happening to these people that quite clearly are so distressed they shouldn't be in that setting?
Thank you very much, Michelle. I think you, without, and I know Pam and the team won't, but without talking about individual cases, I think there's a really interesting lens to look at delayed discharges, but we more than often spend our time talking about the impact that delayed discharges have on flow in the acute service. But I think there's an interesting conversation to have here, and I'll bring Pam in terms of how are we supporting those individuals who are delayed in the hospital more often than not than we would like, people who are in inappropriate areas, both for their well-being and for the service. Pam, and maybe Louise as well, if you would like to come in as well at some point. Thank you.
So we've, you know, I can't comment on individual cases, and I don't know the individual cases or the people, but I'm really interested to hear your experience of care, Michelle. You know, and we do recognise that we do have a lot of people in the wrong place who are waiting for care. But we are engaged through the national work streams around urgent and unscheduled care. We've got a very focused programme of work called Discharge Without Delay. All people who are admitted have a planned date of discharge. So we've got a number of processes that we work to and that we measure against. Clearly the issue in the system is one of capacity. You know, we're unable to staff care at home. You know, our staffing challenges, we're not immune to them in health and care. You know, they exist across our corporate service, they exist across the hospitality industry, etc. So a very, very challenging workforce profile. One thing we know is that you know, people are in a safe environment if they're in hospital. You know, if we can't just send them home without the right care component. So that's another reason why people perhaps wait in hospital. So you know, lots of systems and processes that we undertake across a whole system. We aim to work as a whole system, you know, to be cited on all of the people who are in delay. And people will be in delay for many different reasons that may not be obvious to you know, people bystanding or people not engaged in the process, if you like. A lot of legislative procedures are in place to protect people, and some of that protection is about us not being able to move them until we've moved through particular processes, for example, such as guardianship. And one of the issues, and this is not to blame other sectors, but one of the issues is that we often have to wait for that legal process, you know, for lawyers and legal people to come alongside and work people through processes. So it's multifaceted, but what we do is we measure through quality and safety, as we were talking about earlier. You know, we do assess and understand people's impact of care, and also part of that is understanding staff experience as well. You know, so we often do checks. We you know, we're in Raigmore. We've got staff from community who in-reach into Raigmore. We work very positively with good working relationships across the whole service, and we're solution focused in terms of when the pressures come on us. So unfortunately, yes, people are delayed in hospital, but they wait for many different reasons. And I know that staff across the whole service are absolutely passionate in terms of trying to promote a good experience of care and getting people to the right destination, despite the daily challenges that we face in terms of you know, pace and delay, and the knock-on effect to you know, people like yourselves who are in receiving elective or medical care. You know, we're very conscious of that as well. Thank you.
Thank you, Pam. Louise?
Yeah, just I'm not going to repeat what Pam said because she said it very well. I suppose just to add to it, we will have people that are particularly but not exclusively within the mental health services, that we're really trying hard to find appropriate solutions for their care, because there currently aren't any. So there will be some people that will be delayed for those reasons, and we don't necessarily differentiate those in the information, and perhaps we ought to do a little bit more of that. Maybe there is more of that qualitative look at the delayed discharge data to understand, you know, I'm a delayed discharge, you're a delayed discharge, there's a difference between us, and what is that and why? So I wonder if maybe there's a little bit more information that this committee needs to understand the context of it, because there will absolutely be people that are waiting because there's no care home capacity where they are, but there will be some that, because there's no care home that will take them for their complex needs. So I think it would be a useful exercise just to do a little bit of work with the committee on that.
Yeah. Okay.
Thank you, Louise. Michelle, I know that doesn't answer the question as to why this particular individual is waiting in hospital. I think what Pam has highlighted there is a whole range of complex issues, and we do support staff when they're in there. But I think Louise's suggestion there, in terms of understanding a little bit more about the humanity behind the numbers, would actually be really quite important for us, and it plays right back into that discussion we had right at the beginning of the meeting in terms of quality, because this just takes right back into that. So thank you very much for that question, Michelle. I think it'll give us a lot of food for thought. And I'm going to give you the honour of the final question,
or maybe a couple. I just wanted to make just a comment, pick up on what you've just been saying there, Jerry, about the quality discussion earlier. I'm afraid I haven't looked in detail at what was there about the work plan for this meeting, but in terms of next year's work plan, I think it would be really interesting at some point to, might be a development session first of all, to have a discussion about the relationship between the quality agenda and the IPQR data that we get here. And, you know, as Louise said, what's essential about the rollout of any approach to quality is that the teams own the quality measures that we look at. So clearly, the ideas, you know, I'm sure our teams will have a lot of ideas about to put forward about that. So just you know, I think it would be interesting to have something in our work plan about that for the year ahead. Anyway, I just had a couple of areas to ask a question about. As Pam said, capacity is a real issue for us in terms of improvements around our delayed discharge situation. I wondered, Pam, if anybody can say a little bit more about the solutions that have been agreed in the short life working group, and whether we're going to face any particular challenges in implementing those, or whether, you know, and give us some sort of idea of when you might hope those would have an impact. And similarly, in relation to the medium-term situation, you know, for some time the report has referred to difficulties in advancing that because of resource issues, and I just wondered what your thoughts are, you know, if there are plans to try and address those resource issues and move forward with that medium-term thinking. And then the other area, and this may not be something that can be answered immediately, Jerry, but I read a really interesting piece this week. It was just something that caught my eye in one of these bulletins that appears in one's inbox about how we need to rethink mental health support to young people, particularly because of the increased acceptance and familiarity with information technology amongst young people, and they're being much more receptive to remote means of delivering support. So I just wanted to throw that out there in Arlene's direction to see, you know, to what extent she thinks we are on that agenda in terms of developing the mental health strategy and implementing and using that as a means to try and improve the situation, particularly for our young people, but presumably also there are young adults who are much more receptive to that way of working in terms of psychological therapies as well. Thanks.
Thank you, Anne. Pam, do you want to pick up the first bit, and I'll maybe say to Arlene, I think we will pick up the second bit in a future piece of work. I think it'd be an excellent topic for a development session in terms of how we actually adopt and adapt services to reflect that. But I'll let Pam come in on the first point.
Okay, thank you. So, yes, a focus on people who are delayed in having a poor or suboptimal experience of care, is absolutely critical for us to address and provide the assurance that we're addressing. There are a number of work streams we're taking forward, but what I would say is largely in the population. If we think about prevention and the support that we do provide to people at home, that has to be key in terms of our overall approach in terms of preventing people becoming frail and needing to come to hospital or have an inpatient care episode for rehabilitation reasons, etc. So the short life working group you're referring to, Anne, is that the one about discharge without delay, specifically in relation to delayed discharge? Is that the one you meant?
It's the one that's referred to in this report, Pam, under the care at home slides. It's been referred to for a while. Sorry, I don't have the slides up on my screen in front of me, so I'm not sure if I can get them.
We've done a number of actions and outputs from that group. We've been working with partners looking at block contracting, about bringing people more into the multidisciplinary team. There are some financial challenges that we've been facing around that, just in terms of standing financial instructions and their ability to actually block contract with providers, but that shouldn't be a barrier. One thing we found as well is that we've done an awful lot of work, and an awful lot of people have done an awful lot of work around care at home and trying to solve some of the difficulties, either from the board provided service and or working with our providers across the third and independent sector around care at home, we've had many different people trying to do many different things. So what we've done is we've set up a specific board now to take forward some of those work so that we can understand it and measure it a bit better than we have in the past. And Simon can give you a few headlines about that in a minute. In terms of affordability, we do have people coming into hospital and delayed in hospital, and that's a hugely expensive resource. And we have a number of agency staff, wrapped around that. Very difficult for us to provide services in the community. Staff will largely want to work in Inverness, so in terms of workforce choice and staff experience, that's a huge issue for us. It costs a considerable amount of agency and on cost to get people onto Skye to work in our care home in Skye, and as we go further away from Inverness, it's very, very difficult to deliver care at home services and get providers to deliver services in areas where we can't get workforce and where that's not affordable. In terms of going forward, we are hoping that through our joint strategic plan and a kind of a project charter, if you like, and through a number of work streams, we'll be able to continue to implement and improve what we're doing. But we must, I have to be open with the committee that this is really, really challenging. A lot of it has got increasing on costs on top of what our financial settlement is. We're overspending as a board on agency and lots of extra capacity due to ongoing increasing demand for services and increasing demand from the population. Simon, I'm not sure if you're here and you want to talk a little bit about care at home. or he's maybe dipped out.
Wouldn't miss it, I'm here.
Oh, yeah, I can't see your name on the list, sorry. Are you still there, Simon? Do you want to give Anna a few headlines about the care at home work we were discussing and being assured about in the joint officer group on Friday? Because I think that would be worthy for the committee to hear verbally, and then we can maybe bring out a bigger paper back, a more robust paper back in the future. Thanks, Simon.
Yeah, okay, thanks. Is it okay, Chair, just charge in and be very
yes,
quick?
absolutely, Simon. Thank you very much.
Okay, so the first thing that we need to take into account is our current position with regard to care at home. So the situation remains largely the same as it has been. We are 2,600 hours short on care at home. That's important for members to be aware of, because what that means is the work that we do to improve the position is actually getting us back to where we were. It's not about expanding. So that's a significant change. At the moment, we've got a lot of work taking place, working directly with the sector. We've got some shared proposals that we've been building up there at a very advanced stage now. And our hope is that we can build a care at home collaborative with the sector. We've been looking at the benefits of different forms of contracting. I need to give a caution. People have a tendency to say a block contract would sort. We're pretty close to a block contract at the moment. We actually pay for assumed hours and then do reconciliations. So the issue that we need to actually get much more into, which the sector are up for, and we need to set the practice governance around, is the idea of rapid allocation and rapid review. So it's that bit about packages moving up and down, which we need to do with the sector without having to go through bureaucratic processes if we can. We are initiating a review with the sector of the contract. We're initiating a review of the flexibilities that we're able to offer them. We have put in place a staff member, a joint post with the sector to try and boost and promote recruitment. And we have been successful with our own recruitment in terms of some of the stopgaps, which particularly around the reserves programme that we've described to you previously, where we're up to over 70 people there now. So that's pretty positive. What we are also looking with the sector at the moment is a way that we structure runs as opposed to zones. So members will remember that we zoned Highland at the request of the sector, and then had primary and secondary providers. They're quite keen that we take that maybe down to a run-based approach, and we're looking at how we can do that at the moment. Probably our biggest issue that we've got is where sector providers are unable to continue, we end up with handback. And of course, that then means that we become potentially the provider of last resort. Although I have to advise the committee, there's been some really good examples recently where a provider has stepped out of the provider base, but another provider has come in. So that certainly gives us some hope. And then finally, I would like to make a comment, partly because Arlene is here. We can't do the two things together, but we need to be very careful that we don't just look at care at home and not look at support. So support is also a type of care at home. It works somewhat differently, and it is under similar stresses and pressures. And the issues of provider failure are becoming more to the fore there. And when I say failure, I don't mean that they're failing as individuals. What I mean is that their endeavour no longer continues to be viable. So we do have people coming out of the market there again. The overall picture I would give you, members, is we are doing everything we can to stem the flow, but we are not growing. It's absolutely essential that you understand that. And that means that moving forward on the basis of two things, we'll have to work within a constrained footprint or provider base. The first is we are not seeing that we're going to get huge numbers of additional staff anytime soon. Therefore, we're going to have to work with what we've got. And that may mean that we have to increase our reliance on things like digital solutions, and also reduce the number of inefficient systems we have, such as double handing, etc. And we're doing work around that. The second issue that we need to bear in mind is the one that Anne Clark referred to earlier on. We still do not have absolute clarity about what the financial position is going to be next year, but obviously it will be a very significant concern to us if we are having to operate within a smaller financial envelope for care at home when we've already got a depressed level of care at home. And the same would also apply, obviously, to care homes and also to support work. Sorry, that was a bit of a canter. I do apologise, but tried to be quick for you.
No, thank you very much, Simon. I think there's lots of good context in there, and I'm sure we could actually continue this discussion for the rest of the afternoon. Anne, are you content with? Well, not content, are you?
Well, clearly not in terms of, you know, the situation we're in. But I just, you know, I asked the question mainly because you know, sometimes I'm well aware of the amount of work going on behind the scenes, and sometimes, you know, we have the reports can't go into that in detail. And I think it was important to hear some of the, you know, some illustrations of the considerable amount of work that, you know, some of us know is going on behind the scenes. Despite the fact that, as Simon says, we're largely stemming the flow rather than managing to grow the capacity. So that was very helpful to hear that, Simon. Thank you.
Thank you very much, Anne. I'll draw this item to an end. We've been asked to accept, as a committee, accept moderate assurance. Are we content to do so? I think Simon's point about actually all we're doing is stemming the flow. We're not growing the system at all at the moment. It's probably a key one to take from that. But are we content to take moderate assurance? Not seeing anything to the contrary, so we will accept moderate assurance from that. Now we're running about 10 minutes late, so I'm going to suggest that we take a quick 10-minute, and I will extend it to 10-minute comfort break, caffeine break. And let Pam prepare herself for probably 2 or 3 items that she's.
No, I've just been starting a bit of sneeze and I realised my microphone wasn't on. I was like, oh, I'm so sorry, but yes, I would be grateful for the break before the next bit.
So we'll come back again at 22, and then we'll go straight into the joint strategy and the balance of the agenda. Thank you. See you in 10 minutes.